So rheumatic heart disease is an inflammatory disease that occurs in children and young adults. This is caused by an infection of a group A streptococci, which causes strep pharyngitis. Some of these strep bacteria have an M protein on their structure that is highly antigenic. These antibodies cross-react with proteins in our own body, which then undergo molecular mimicry and attack a structure known as N-acetylglucosamine. These are seen in connective tissues and cause a wide range of reactions. So these reactions are considered a type 2 hypersensitive reaction. The pathological feature of rheumatic fever are Ashkoff nodules, which are found in heart cells during inflammation. So the key feature of rheumatic heart disease is that it can involve all the heart layers, as in it causes pericarditis. We have the outermost layer, the pericarditis, then the myocarditis, and the innermost layer, the endocarditis. In pericarditis, the features occur after a sore throat. The onset is usually after 2 to 4 weeks and results in the inflammation of the outermost layer. Patients from ages 5 to 15-year-old come in with chest pain. An ECG would show a concave ST elevation present in all leads except the AVR. During auscultation, a pericardial rub can be heard. Treatment for this is with steroids. The disease can also occur in the myocardium. Myocarditis can lead to a series of complications. It then continues on to becoming heart failure. Dilation causes a reduced function of the valves, resulting in mitral or tricuspid regurgitation. This results in a pansystolic murmur and manifests usually with pulmonary edema. Treatment is remembered with the mnemonic LMNOP. L stands for Lasix, a diuretic like furosemide. M is for morphine, N is for nitrates, O for oxygen, and P for position. Morphines vasodilate, decreasing the preload. Nitrates reduce the preload and the afterload. Oxygen is used, and an upright sitting position is kept to reduce venous return to the heart. Endocarditis usually involves valvular lesions. The most commonly affected valve is the mitral valve. The pulmonic valve is almost never involved. Valvular lesions, either a mitral stenosis or regurgitation, can be seen. In patients aged from 5 years to 15 years, the incidence of mitral stenosis is seen in younger patients, and mitral regurgitation is seen in older. Some patients can have both, and this is because the vegetations in rheumatic fever involve the tip of the valve, known as commissural lesions. Due to the lesions on the tip, the regurgitated blood, as it comes back into the ventricle, can cause a Carey-Coombs murmur. The incompetency of the valves damage the free wall of the left atrium. This is known as Malcolm patches. Mitral valve is usually treated with surgery. If the space between the valves are less than 1.5 cm square, a percutaneous balloon mitral valvotomy is done. For mitral regurgitation, a valvuloplasty or a prosthetic valve is given. The second feature is arthritis, the swelling or redness of joints. It is an early manifestation of rheumatic heart disease and is considered the most common manifestation. Arthritis is essentially swelling or redness of the joints, ankles, knees, or elbow. The arthritis jumps from one joint to another, known as migratory polyarthritis. The treatment for this is aspirin. Remember that in rheumatoid arthritis, it involves small joints, and rheumatic arthritis involves large joints and is non-erosive. The next feature is called a Sydenham chorea. Chorea itself is seen in Huntington disease. Sydenham chorea is slightly different. It's asymmetric in its manifestations. It has a late manifestation in rheumatic heart disease, and the lesion is to the caudate nucleus. You see an involuntary movement of the hands and the involuntary movement of the tongues. This results in a poor hand grip and hand reflex. The tongue spasming results in unclear speech. The treatment for this is usually self-limiting and resolves by itself in 6 to 12 months. Drugs are given to the patient, although they have to deal with the side effects. Anticonvulsants such as valproic acid and carbamazepine have shown to be effective. Steroids are widely used. Dopaminic blockers such as haloperidol are effective and well tolerated on a small dose. Prednisone plasma exchange and IV immunoglobulin injections can also be given. Subcutaneous nodules are quite a rare manifestation of rheumatic heart disease, and so the presence of firm cutaneous nodules in an extensor distribution is highly suggestive of rheumatic heart disease. Sites involve bony surfaces such as the tip of the spinal processes of the vertebra, elbow, knees, wrists, ankles, and the occipital bone. Erythema marginatum are reddish spots similar to the rose spots seen in typhoid patients. The symptoms just discussed are considered the major criteria for this disease. The minor criteria include fever, arthalgias, as in pain in the joints, which could be mono or poly, prolonged PR interval, which indicates a first-degree heart block, usually caused by Ashkoff nodules between the SA and the AV node. The other essential criteria that we need for diagnosis is that during an ASO titer and anti-streptolysin O titer, the value should be elevated, which indicates an evidence of recent strep infection. This is only significant if the patient is infected in the last 45 days. The time frame is important, and that's because chorea develops as a late feature. It can develop as late as after 3 months, in which case the ASO would be normal. A throat swab or a streptococcal antigen test can help with diagnosis. The mnemonic Jones piece is commonly used to remember the criteria. Let's review through the symptoms and its key points. So the major criteria includes joints, heart, nodules, erythema, and Sydenham chorea. The joints have migrating polyarthritis and is treated with aspirin. The heart can flare up pancreatitis and is known for its valvular damage. We need to look out for Carey-Coombs murmur and McCallum patches. Nodules meaning subcutaneous and extensor surface nodules. Erythema are painless rashes. Sydenham chorea is the flinching movement disorder. Minor criteria is remembered with PEACE, previous rheumatic fever, ECG with PR prolongation, arthalgia, CRP and ESR are elevated, and elevated temperature. And the essential criteria include increased ASO titers, more than 350 units for children and more than 250 for adults, a positive throat culture, and a recent scarlet fever. So the algorithm for diagnosis is that the patient should be positive for either 2 major criteria and 1 essential criteria, or 1 major and 2 minor criteria. Treatment depends on the severity of the rheumatic heart disease, but the following steps are helpful in managing the patient. So step 1 is eradicating the cause of the infection, which is by giving antibiotics for streptococci. Then use an anti-inflammatory treatment. Aspirin is used to treat arthritis, and corticosteroids are used to treat carditis. The next step is to provide supportive management and also manage the complication. Patients are advised to have bed rest, and you also treat other complications like congestive heart failure or chorea. After treatment and management, prevention is the next step. So step 4 is secondary prevention of rheumatic fever. So it is recommended that patients take penicillin injections every 3 weeks for the rest of their life. Because that's not ideal, the following are the recommendations for patients with different types of complications. Patients with rheumatic heart disease and mitral regurgitation require injections for a minimum of 10 years from diagnosis and are recommended till 40 years of age. Patients with rheumatic heart disease and no valvular involvement is a minimum of 10 years from the diagnosis up to 21 years of age. And for patients with rheumatic fever, it's a minimum of 5 years from diagnosis up to 21 years of age. A quick note with arthritis and chorea. Arthritis is an early manifestation and chorea is a late manifestation. The occurrence of symptoms can help you estimate the timeline of the infection in your patient. If the patient is allergic to penicillin, erythromycin is preferred over sulfadiazine.